beta blockers. Beta adrenergic blocker, they are the first line drugs which in mild to moderate hypertension. Okay, when if a patient has mild to moderate hypertension, they can be considered as first line drugs. Okay, so that means they are of course more important than the alpha blockers. Okay, now the mechanism of action, they decreases in heart rate and contractility, and okay, when the heart rate is decreased, when the contractility is decreased, that causes decrease in cardiac output, and of course that will lead to decrease in blood pressure. That there is a decrease in peripheral vascular resistance. Now how does that so? Because as I told you before, that beta receptors are mostly present on the heart. So how on earth the peripheral vascular resistance is decreased? Because arterioles, because of which the resistance are getting decreased, do not have beta receptors. Well, I will tell you this just in a few minutes. Okay, so basically that is decreased, and after a long term use, because of reduction of cardiac output, which leads to decrease in both. It doesn't make sense right now. I will explain you with the diagram, and then it will make sense to you guys. There is decrease in renin release from JG cells, juxtaglomerular cells of the kidney, and that causes decrease in the formation of angiotensin 2. Okay, before going on to the advantages, let's just look at this diagram first. Okay, this is the diagram for beta 1, by the way. This is the diagram for beta blockers. Again, the same diagram, but here we will talk about beta blockers. As I told you, most of the beta 1 receptors are present on the heart. So you have beta receptor present on the heart everywhere, on the ventricles, on the SA node, on the AV node, everywhere. All the heart is basically is filled with beta 1 receptors, and there is beta 1 receptor on the JG cells. So guys, remember, beta 1 receptors are present on two parts in the body, on the heart and on the kidney in JG cells. So you have beta receptor 1 here and here. Okay, and these receptors are getting supplied by neurons, sympathetic neurons, of course. Sorry, the diagram is so crappy. So now beta blockers, they actually work by two ways. They act on the heart, and they also act on the kidney. When they act on the heart, basically when beta 1 receptors are activated, they produce contraction. They are an stimulant receptor. You know, when they are activated, they produce contraction, increase the force of contraction, increase the conduction through AV node. So everything is increased, like heart rate is increased, contractility is increased, cardiac output is increased when these receptors are activated. But when you give an antihypertensive patient beta blockers, these receptors are blocked. Woohoo, these receptors are blocked. When these receptors are blocked, then basically the neurotransmitter, the norepinephrine, which is getting released from these sympathetic neurons, won't be able to act on these receptors, and hence the beta mediated action is blocked out. Basically the contractility of because you know the muscles of the ventricles contain beta receptors, so the contractility of the ventricles is decreased. The heart rate is decreased. How? Because the AV conduction, the conduction through AV node is decreased, so heart rate is decreased. And this is very important. You will come to know later in the video how this SA node part is important. So anyways, the conduction through SA node is increased, the contractility is increased, and when all these things are decreases, sorry, did I say increase? Actually everything is decreased. Anyways, when these contractility and conduction is decreased, the heart rate is decreased, the cardiac output, the blood that is getting ejected, stroke volume, that is decreased, and that leads to decrease in blood pressure. So everything is done here about the heart. Now talking about the kidney bit, when there is increase in blood pressure, when there is change in blood pressure, anything, these JG cells senses the change in blood pressure, and what they do is they release an enzyme called renin enzyme. Yeah, the renin enzyme act on an inactive substance which is getting released from the liver, which is called angiotensinogen, and then a renin, which is getting released from here, from the kidney, from the nephron. And these renin act on angiotensinogen and convert it, sorry, basically angiotensinogen here is getting converted into angiotensin 1 when acted upon by renin. Okay, and these angiotensin 1, let's suppose if there is a liver here, and that liver releases angiotensinogen, because this metabolites, this substance here comes from liver. So angiotensinogen is then acted upon by renin, which is getting released by this kidney. Okay, angiotensinogen then is getting converted into angiotensin 1 and is then enters into the right hand side of the heart, goes into the lungs, and lungs, these pulmonary vessels, they have on their endothelial cells, they have an enzyme called ACE, which is angiotensin converting enzyme. They convert this AT1 into angiotensin 2, and this substance here has a very important role, because angiotensin 2 receptors are present on the veins, on the arterioles, and you know what, when they act on these arterioles, they produce constriction, you know. So when beta 1 receptors are getting blocked, they do not they do not stimulate, they won't get stimulated, of course, and then they won't release, these nephrons won't release renin, and when the renin is not released from all these pathway, angiotensin 2 is not getting produced. When they are not getting produced, basically these arterioles here dilate, and peripheral vascular resistance is what is dilated, is really is decreased. So yeah, that leads to a contribution when there is a long-term use of beta blockers. The advantages of beta blockers is that there is no postural hypotension, this is not significant, and salt and water retention. Why? Because there is no salt and water retention. You know why? Because if you look at this diagram here, the A2, angiotensin 2, also act here on zona glomerulosa. This is the adrenal gland, this is the cortex, this is the medulla. On the cortex you have zona glomerulosa cells, and zona glomerulosa cells has angiotensin 2 receptor, AD2 receptor. Okay, when AD2 receptor here, when angiotensin 2 act on these receptor, they releases aldosterone, and aldosterone act on the late part of the nephron and causes you know, and causes retention of salt and water. So when because when there is no angiotensin 2, there is no release of aldosterone, and aldosterone cannot act, and so there is what, excretion, okay, of water and salt, and hence the blood volume comes down and blood pressure is under control. So there is no salt and water retention, as I said. Low incidence of side effects and low cost, and once a day regimen, prevention of sudden cardiac death in post infarction patient, and progression of congestive heart failure. Their side effect is fatigue and lethargy, may precipitate congestive cardiac failure and bronchospasm, difficulty to stop suddenly. But I would like to focus on these two: fatigue, lethargy, and bronchospasm. You know why? Because these side effects are taking place because of okay, lethargy, decreased work capacity, bronchospasm. Guys, the one that is highlighted here is taking place because of the beta 2 receptors. It's not because of beta 1. You know, beta 1 receptors are present on the heart and the JT cells of the kidney, but beta 2 receptors are also present on the vessels, on the smooth muscle cells of the arteries that is supplying the skeletal muscles. So basically what happens is and the action of beta 2 receptors is that they are not stimulant, they are inhibitory. So when you stimulate beta 2 receptor, they produce dilatation, relax, they are inhibitory. And again, guys, this is something that you should be aware of from your previous lessons on just the adrenergic receptors, adrenergic there is like a whole chapter on adrenergic drugs, and from that chapter you guys should know the different types of beta receptors and their different actions and distribution. So as I said, beta 2 receptors are present on the arteries, which is supplying the skeletal muscles, and when they are stimulated, they produce dilatation. Again, dilatation, not constriction, dilatation. When these beta 2 receptors are blocked, what they do, they constrict the vessels. When they constrict the vessels, less blood is getting supplied to the skeletal muscles. So there is less supply of oxygen, less supply of nutrients. Ugh, anyways, I can't even say that. Anyways, nutrients are not getting supplied, oxygen is not getting supplied to the skeletal muscles, and so you develop fatigue and lethargy, and there is decreased work capacity. And bronchospasm is because the bronchioles, the smooth muscle cells of the bronchioles, have beta 2 receptors, and again their work is to dilate, okay, cause dilatation. Okay, so when that receptor is blocked, there is a spasm, constriction of the bronchioles, and that can may precipitate into asthma. So these two are thing because of the beta 2 receptors. Okay, so that's why you give beta 1 blockers, cardioselective drugs, rather than non-specific drugs. Anyways, cardioselective drugs are preferred now. Why? Because of these side effects. They can be given safely in asthma, diabetes mellitus patients, peripheral vascular diseases. The current status of beta blockers, they are the first line of antihypertensive along with diuretics and ACE inhibitors. Okay, so they are the first line of antihypertensive drugs, and which other drugs are the first line antihypertensive drugs? They are the diuretics and ACE inhibitors. They are preferred in young and non-obese hypertensive patients. They are effective and well tolerated and are of special value in angina or post-MI patients. They are useful in preventing mortality. May be used in combination with other antihypertensive, particularly with those that causes tachycardia as their side effect, like vasodilators. And again, guys, you have to just understand, use your brain here. They can be given along with other drugs, and the combinations are preferred with the drugs that produces tachycardia as a side effect. And we just looked about alpha blockers, they produced tachycardia as a side effect. So you can combine with beta blockers. Why? Because beta blockers, again, I told you, right? Beta blockers, what they do is they decrease the conduction through AV node, because they block out the beta 1 receptor is present on the AV node, and so the reflex tachycardia, which is getting produced as a side effect of alpha adrenergic blockers or vasodilators, will be counteracted by these beta blockers, because they produces tachycardia, and that will be blocked out by beta receptors. Because it makes sense, tachycardia means increase in heart rate, and increase in heart rate is only taking place because when there is increase in conduction through AV node, and that is getting blocked out by beta receptors. So yeah, that